as patients. راح يكون على parts because it's a long lecture, so we're going to talk about a lot of things. The general layout will be general principles of management, cardiovascular, endocrine, respiratory, gastric, hepatic disease, neurological diseases, and bleeding disorders. These are the most common things that we might find at any patient, so that's why we need to talk about the most common things. Now, let's talk about general principles of management. Whenever any patient comes to the clinic, we always start with the basics. We take the patient's name, the patient's information, then we talk about the chief complaint. What's the main reason for the patient's visit to the clinic today? Then this chief complaint could be pain in the teeth, could be due to TMJ disorder, could be due to oral lesions, could be due to many things. So first thing, we need to take the chief complaint in the patient's own words. So the patient said, I have pain in my teeth. We write it as it is. Then we start talking about the history of the chief complaint. There are a lot of things to ask about this history. Let's say the patient has pain. First thing we should know, when did this pain appear? This pain appeared a few days ago, a month ago. We need to know the onset of the pain, the duration. How long does it stay? Does it stay for like 10 minutes, 15 minutes, an hour, or more? We need to talk about the features of the pain, or the pain it is. Is it continuous? Is it intermittent? Is it all the time within an hour? Let's say the pain remains an hour. It stays an hour, or it comes like for 5 minutes, 10 minutes, and then goes away and then comes back. So intermittent or continuous. Then we ask about the aggravating factors and the relieving factors. The factors that will cause the pain to be worse and the factors that might cause the pain to be less. So for example, as we all know, irreversible pulpitis, we all know that heat aggravates it and cold relieves it. It's a classic sign that the patient, when he comes with a cold water and he starts drinking to relieve the pain, we know it's a classic sign of irreversible pulpitis. Okay? We need to ask about the location of the pain. Is the patient able to locate the pain in the lower arch, in the upper arch, or is it vague? Sometimes he feels it in the lower, sometimes he feels it in the upper. We need to ask also about the patient's pain in the oral region. Does it radiate to some places? Like, does the patient feel the pain, let's say, in the upper 8, but then he feels the pain in the upper 5 or in the lower 6? These are also important factors that we should know. So first, we take a very good history of the pain itself. Then we go medical history, dental history, social history, smoking, nargile, then extraoral examination, then intraoral examination, and investigations. Investigations can be labs, if needed, x-rays, panoramic x-rays, periapical x-rays, whatever it is. Then once we have the full picture, we can make a diagnosis, differential first. We place a lot of specific features, like this pain can be associated with, let's say, irreversible pulpitis. Then it can be associated with TMJ disease. Yeah, we place the most common first, then we go to the least common. Then we can formulate our diagnosis. Then we can formulate our treatment plan. What is the plan that we should go through? And then we go to the treatment. So first, let's talk a little bit about clinical tests and the normal values. Let's say it can be seen a lot, that we have a patient presents you with lab results. If you don't find the normal values, you will not be able to say if it's normal or not. But sometimes it's easy. For example, the white blood cell count usually between 4,000 to 11,000 cells per milliliter. So if it's above that, we can anticipate an infection. Red blood cells between 4.5 to 6 million cells, or in females 4.5 to 5 million cells. Platelets 150,000 to 450,000. Hemoglobin in males 13.5 to 17.5, in females 12 to 15. The mean corpuscular volume 80 to 96. Now this is important in cases of anemia. We can classify this as microcellular or microcytic anemia or macrocytic anemia or normocytic anemia. Okay. The hemostasis, the bleeding time between 2 to 8 minutes. The prothrombin time 10 to 13 seconds. Activated partial thromboplastin time 25 to 35 seconds. These are important in patients who have medical diseases, or the patients who take warfarin or stuff like that, aspirin. These hemostatic tests are important, or what we call a coagulation profile. Okay. So the chemistry, the glucose fasting should be 70 to 110. Now we will talk about this more once we go through the endocrine. Okay. So some tests are important because they are associated with specific diseases. Here, for example, we have the anti-Ro and the anti-La associated with Sjogren's syndrome. We have the lupus anticoagulant, antithrombin antibodies with systemic lupus erythematosus, rheumatoid factor with rheumatoid arthritis, and more. So let's talk now a little bit of general anatomy. Now, some features, some diseases, we need to understand the basics. So, for example, the heart, it has 4 chambers. We have two ventricles, and 2 atrium. Now, how does it start? Blood comes through the superior vena cava into the heart, into the right atrium. Now here the blood is deoxygenated. It goes down into the right ventricle. Through there, it will go to the lungs. Now, as we all know, all arteries give us oxygenated blood. But here, the pulmonary artery gives us deoxygenated blood. It transfers the deoxygenated blood from the right ventricle into the lungs. Once the blood gets oxygenated there, it goes from there through the pulmonary vein into the left atrium. Then from the left atrium into the left ventricle, and then into the whole body. Okay? Through the aorta, of course. So this is the basic how it goes. Now we have what we call coronary arteries. Now these coronary arteries, they take from the aorta as seen here and supply the heart. The heart itself is a muscle. It needs blood to function. And that's important for us. So the heart, to keep functioning, it needs blood. So it takes from this by the coronary arteries and supplies the heart. Now, once we have the blood going through the aorta and everything is fine, we have what we call baroreceptor reflex. The baroreceptors, these are specific chemical messengers. They are placed within the aorta, within the blood vessels, and they function to assess any reduction in blood pressure. Once the blood pressure reduces, if it happens, they will send a message to the vagus nerve, telling it that we have low blood pressure. What do we have to do? Now, they will activate the cardioinhibitory center, which will go through to the vasomotor area. Now, this will activate the sympathetic ganglia, which will activate a fight or flight situation, meaning it will cause vasoconstriction, so there will be smaller space for the blood to go through. This will raise the tension, and this will raise the blood pressure, and they will go through to the kidneys to activate the renin-angiotensin-aldosterone system. Now, the renin-angiotensin-aldosterone system is very important. It starts with angiotensinogen, the inactive state of angiotensin. This is present. Now, angiotensinogen is present in the lungs. It transforms into angiotensin 1 in the lungs. Then it becomes angiotensin 2 in the kidneys. Now, is this important? Yes. Why? Because renin will activate the angiotensinogen. Then it will activate the angiotensin 2. Then angiotensin 2 will give us aldosterone. It will tell the adrenal gland to secrete aldosterone. This aldosterone system will bring all the fluids back from the kidneys into the heart, into the blood vessels. So, let's go back a little bit. The blood pressure equals the cardiac output multiplied with the peripheral resistance. Cardiac output is the amount of blood passing through the vessels, simply put. And the peripheral resistance is the resistance of the vessels. So, the sympathetic system activated both of those, raised the blood pressure. How? It brought back the fluids from the kidneys into the blood vessels, which caused the cardiac output to increase, and it activated vasoconstriction, which caused the vasoconstriction causing the peripheral resistance to increase, causing increased blood pressure. So in the sympathetic, we would increase the heart rate and the contractility. In the parasympathetic, we would reduce the heart rate and the contractility. Now, let's talk about the coagulation cascade. We have two pathways, intrinsic and extrinsic. And the common pathway that is common between the two pathways. The intrinsic pathway, usually there will be a surface contact, a wound, whatever it is. It will activate factor 12, then factor 12 will activate factor 11, then factor 9, then activation of factor 10. It's a long process, let's say. The extrinsic pathway, only one factor, factor 7 gets activated, goes all the way back into factor 10 to activate it. Now, once factor 10 is activated, it will be helpful in the process of the activation of prothrombin into thrombin. Thrombin will be helpful in the activation of fibrinogen into fibrin. Then factor 13 would be also activated by the thrombin, causing fibrin to become stable fibrin clots. So this happens when we have a wound, when we have an injury. There is a laceration. Now this laceration, the first thing that will happen, von Willebrand factor and the platelets will form a primary clot to keep it from bacteria, aerobic and anaerobic bacteria, to keep it stable and safe. Now, through this, we will have this coagulation cascade happening to become the secondary clots, which will be more stable, more strong, that it can withstand any small physical activities, if it's in the hand, for example, or whatever. So, in the intrinsic pathway, From the inside, we will have factor 12, factor 11, factor 9, activating factor 10, activating thrombin, then fibrin and factor 13, becoming stable fibrin clot. Now, fibrin is an adhesive. It will adhere to each other and become the clot that is present. Now, the last thing before we talk about the disease. Okay, the last thing before we talk about the actual diseases. So this is just an introduction so we can understand what we're talking about once we go through the actual diseases. It's a long thing, sorry. Now, the pancreas secretes alpha cells, beta cells, gamma cells, and F cells. Sorry, delta cells. Now, alpha cell secretes glucagon, which is secreted in cases which we need increases blood glucose. We need to increase the glucose in the blood. Now, beta cells, they secrete insulin, which will decrease the glucose. The delta cells, they secrete somatostatin, inhibits insulin and glucagon secretion. The F cells, pancreatic polypeptides. Now, let's talk about something we call the negative feedback inhibition. Now, once we have any secretion, let's talk about, for example, the adrenal gland. It secretes cortisol. If the cortisol levels decrease, the adrenal gland will send a signal to the anterior pituitary gland, telling it we have low cortisol. What should we do? The anterior pituitary will go to the hypothalamus, telling it the adrenal gland has low cortisol secretion. What should we do? The hypothalamus is the center of all of information, sends CRH, corticotropin releasing hormone. This will activate the anterior pituitary gland to secrete ACTH. This will send an information, the ACTH, the adrenocorticotropic hormone, will send an information to the adrenal gland secreting more cortisone. And this will release the cortisone, raising it to the normal level. Once it reaches the normal level, the cortisone will send an information to the pituitary to stop the ACTH. The ACTH will send an information to the hypothalamus to stop the CRH. Now, the good stuff. Cardiovascular diseases management. Now, heart diseases are classified into congenital and acquired diseases. Congenital could be cyanotic with cyanosis and acyanotic without cyanosis. The acquired can be ischemic heart diseases, arrhythmia, infective endocarditis, valvopathies, diseases of the valves, myopathies, diseases of the muscles of the heart, and pericardial diseases. Another classification classifies them into organic and functional. Organic, the problem is in the organ itself, in the heart itself. It can be myocardial, endocardial inside the heart, or pericardial surrounding the heart. The myocardial overload, coronary disease, cardiomyopathies, endocardial rheumatic heart disease, congenital anomalies, infective endocarditis, and pericardial like pericarditis or pericardial effusion. The functional disorders can be hypertension, can be tachycardia, bradycardia, hypervolemia, hypovolemia, and so on. Now, the general management, we need a medical consultation most of the time. Most of the time, we need the cardiac physician to give us a consultation if it's safe to extract for this patient, if it's safe to do a procedure for this patient. In specific cases, it's a must. Now, we need to give the patients short, minimally stressful appointments in an upright position. All of cardiovascular diseases except arrhythmia. Arrhythmia, we treat them in supine position to reduce anxiety, exertion, and pain. We use aspirating syringe, so we don't go through a vessel once we give anesthesia. Adrenal epinephrine, they can get into the blood and theoretically can raise the blood pressure and precipitate arrhythmias. Now, endogenous adrenal or epinephrine can have a high level during the morning hours. And most cardiovascular complications or cardiac events can happen in the early morning. So that's why these patients are usually placed in late morning appointments or early afternoon. Late morning to early afternoon, this is the best time to treat these patients. Low adrenaline or no epinephrine presence in the body. Now, adrenaline containing local anesthesia should not be given in excessive doses to patients taking beta blockers. This may induce hypertension, cardiovascular complications, and a lot of things. What's the maximum dose? Now, each carpool or ampoule of anesthesia that has 1 to 100,000 epinephrine contains about zero point zero 0.018 of epinephrine. The maximum dose is 0.04 milligram of epinephrine. Sorry. Now, so we can give up to 2.5 carpools of local anesthesia with adrenaline in the safe levels to a patient with cardiac disease. After that, we use plain anesthesia without adrenaline. Now, ischemic heart diseases, they're not always symptomatic. We can have angina pectoris or MI. Now, the main cause behind it is called atherosclerosis. It is the deposition of cholesterol deposits on the blood vessel. Now, this cholesterol presence on the vessels causes the blockage of the blood vessel, causing what we call atheroma. Okay, so this atheroma will block the blood vessel. Now, it can be a partial blockage, can cause angina pectoris, or complete blockage, which can cause an MI, and this needs immediate management. Now, the usual symptoms for angina pectoris or MI include heavy, crushing in nature chest pain, pain that appears in the chest that is heavy and crushing. Patients can say we feel like knives. مرات المريض ممكن يحكي انه والله عندي حاسس انه زي في اشي ثقيل على صدري او حاسس زي سكاكين بتنخس. Any of those symptoms should alert us to angina or MI. This pain can radiate to the shoulder, to the neck, to the jaws, and these are very serious symptoms that we should know about. Risk factors for development of atherosclerosis: high levels of C-reactive protein, high levels of fibrinogen, a procoagulant, or plasminogen activator inhibitor, antifibrinolytic. Now, to understand this term, fibrinolytic is something that causes the fibrin to dissolve, to cause lysis to the fibrin. Antifibrinolytic means it prevents the lysis of the fibrin, so the fibrin clot remains as it is. Now, ischemic heart disease, at least 20% of patients affected, and it's increasing, and now it's about 35% of total mortality in Britain and the USA. And sometimes the clot or the atheroma can break off and include small vessels causing embolism, which can be pulmonary embolism and causing problems within the lungs. Here we can see atheromatous plaque on the left side, and the right side is normal. Here how it appears. Now, the angina and the MI, they have risk factors. They can be irreversible, fixed factors like age, gender, male, ethnicity. These are high risk factors that will be affected with angina or MI or atherosclerosis. Reversible or modifiable risk factors like high LDL, hypertension, smoking. Now, this is one of the classification systems, something that you cannot reverse or something that you can reverse. The other classification system talks about primary risk factors, high LDL, the bad cholesterol. Now, how to remember it? The LDL and the HDL. Now, L should be low, H should be high. So LDL is the bad one, should be low. H should be high because it's a good one. So that's how to remember it. High LDL, hypertension, and smoking, these can be reversed as we talked about. Secondary risk factor, family history, obesity, DM, low LDL, male gender, Aegeans, gout, and so on. The protective factors, raising the HDL, more exercise, moderate red wine or other alcohol can reduce the risk factors, or they can reduce the risk of atheroma. Now, angina pectoris, it's usually discomfort due to an imbalance. The oxygen demand and the oxygen supply are not equal. Now, the oxygen that we should take, it's not the same as we should give. So simply put, it's like you work in a clinic. Now, like you work in a clinic, if you don't get the enough money or the enough salary that you need to work, you will not continue working, right? Okay, same thing. The heart is supposed to supply blood to the whole body. It's not getting the enough oxygen and the enough nutrients that it's supposed to take. So it's not going to go give its full function as it should be. Stable angina is chest pain that appears only on exercise. Because the heart needs more blood to supply the muscles, it cannot do that, the pain appears. Unstable angina, it does not follow a pattern. It can happen more often, more severe. It can be with or without physical activity, and it's not relieved by medicine. Now, management. We give late morning appointments, stress reducing protocols, local anesthesia is preferred, aspirating syringe, upright position, the things we talked about in the beginning. Now, medications. What can we give to this patient? What do you mean, what can we give? What can we give to this patient as a medication to prevent angina pectoris from happening, to treat it? Now, to treat it, it's not our job, so we're not going to go there. But usually, aspirin, nitroglycerin, sublingual nitrates, or حبة تحت اللسان. Some people can say that as well. Now, let's say once you gave the patient anesthesia, you started working for a filling or an extraction, whatever it is. Suddenly the patient said he put his hand on his chest. He didn't say anything. You asked him what's wrong. He says, there's pain in my chest, a lot of pain. What should we do? We stop our procedure, we don't continue doing it, we put away all the instruments, the sharp ones that might injure the patient, we call 911, we give the patient the nitroglycerin sublingually because its absorption is faster. Then we wait. If the pain is relieved by the nitroglycerin, then that's great. Amazing. The ER will come, the paramedics will come, they will take the patient to the hospital, and they will deal with them there. The pain did not go away. What should we do? Now, this means it's not stable angina. It is either unstable angina or MI, complete blockage. Now, angina can progress to MI, but fewer than 50% of patients can have any preceding symptoms. Ventricular fibrillation is the most common cause of death, and nearly 50% of deaths are in the first hour. Now, features are the same, but associated with dyspnea, shortness of breath, and epigastric discomfort with or without nausea and vomiting, similar to angina. So, what should we do as a general management? We need to know history of the MI and the coronary stent. When was the last time he had an MI? And what did they do to it? Now, a stent is this metal thing that's placed inside the vessel to keep it patent and allows the blood to go through easily. Now, when to operate on these patients? Before, in the old times, they said 6 months. Any elective dental procedure should be done after 6 months to a year from the MI. New, they said up to 3 months, then 3 weeks. But the last agreed on a month. And we'll talk about the article that says that. Late morning appointments, upright position, local anesthesia with epinephrine. Is general anesthesia preferred for these patients? Sometimes yes, because we can find out, like on the ECG. If we don't have cardiac monitoring in the clinic, it's preferable to go for general anesthesia or to do the procedure in a hospital where we can have cardiac monitoring. Now, these patients will be on anticoagulants, so we need to know what kind of anticoagulants the patients are on, and we need to know how long have they been on these medications. Warfarin, aspirin, the novel anticoagulants, the new ones, all of those need specific monitoring. We will talk about them specifically. Now, emergency. Immediate management. What should we do? We call 911. We give aspirin 300 milligrams crushed between his teeth. It's faster absorption this way. We give them rest and reassure and oxygen. Oxygen to keep the O2 saturation normal. Because if the O2 sat reduces and the brain is not getting enough oxygen, we can get into brain death within 4 minutes. Now, tissue plasminogen activators, streptokinase, these are done within the ER. Now, what should we do? Opioids should be given for the pain. Now, to simplify it, we have what we call MONA. Morphine, oxygen, nitrates, aspirin. First, we start with oxygen. We give the patient oxygen, aspirin, nitrates, and morphine for the pain. Now, here the article. The emerging evidence is that no elective dental care should be given within 30 days of MI. Emergency should be done within the physician's consultation. He should give us an okay to go there. Okay? But most of the time, right now, we keep by the 3 months or the 6 months guidelines until, or at least here in Jordan يعني. بس لحد ما يوافقوا على new guidelines, we might hear something new. Hypertension, as we said, it's cardiac output multiplied with the peripheral resistance. It's defined as a persistently high blood pressure, over 140 over 90. Now, it can be idiopathic or primary or essential hypertension, and this is about 90% of the cases, or secondary, about 5 to 10% of the cases. Most common cause is renal disease. We talked about the physiology. The blood pressure is lowest at night and highest first thing in the morning. The patient should be relaxed once we take the blood pressure measurement, and we measure it with a sphygmomanometer. Now, in 1/3 of the population, we can find no symptoms at all. But we can have symptoms and signs of hypertension. Symptoms like headaches, visual disorders, tinnitus, dizziness, angina pain. Signs: hypertension on testing, proteinuria and hematuria, blood in the urine and protein in the urine, left ventricular hypertrophy, and retinal changes, eye problems. Complications: coronary failure, MI, heart failure, and more. Now, the treatment usually first starts with lifestyle modifications. Cutting salt. Salt raises the blood pressure very high. Cutting it will give us like a 50% reduction, if not more. And then drugs. Alpha blockers, angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, beta adrenergic blockers, calcium channel blockers, diuretics, sympatholytics, vasodilators. All are medications that can be given. Now, diuretics can have dry mouth, oral manifestations. Now, ACE inhibitors, they can have angioedema, ARBs as well, angioedema, calcium channel blockers, gingival hyperplasia, and more. Now, management. What to do? General management: stress reduction, good report, short morning appointments, late morning, of course. Consider pre-medication with sedative anxiolytic. We need to have reading before the procedure because the local anesthesia will raise the blood pressure, so we need to have a reading before the procedure. Upright position, aspirating syringe should be used. Now, if we're going to general anesthesia, beta blockers, calcium channel blockers, and clonidine should be continued. Diuretics, ACE inhibitors, angiotensin receptor blockers should be held off on the morning of the surgery if we need hypertension. Now, when not to operate on a hypertension patient. Now, as we all know, the normal level is 120 over 80. Up to 140 over 90, it's considered routine dental care, not actual hypertension. Sorry. Now, 140 to 159 over 90 to 99, this is considered stage 1 hypertension. We need to recheck blood pressure before working. We can keep working here. 160 to 179 over 95 to 109, stage 2 hypertension. We recheck blood pressure, seek medical advice, and we might not work up procedure. Over 180 and over 110, stage 3, it's considered hypertensive urgency or emergency. We don't work there at all. Now we need to put something in mind here, that if the patient's blood pressure once he came to you was, let's say, 170 over 95, with the local anesthesia it will increase. Let's say it became 180 over 105. So here we terminate the procedure. We don't do our procedure for this patient. So the safe level, it's variable, but I would say up to 160 over 90 if the procedure is emergent, if the patient has severe pain and we cannot delay him. But if it's selective, no, control your blood pressure and come back. Now, a new classification emerged, told us that the normal blood pressure are less than 120 over 80, elevated 120 to 129 over less than 80, stage 1 hypertension 130 to 139 over 80 to 89, stage 2 over 140 and over 90. But they kept with both classifications because this classification just told us that we have stage 2 hypertension. So when can we not work? When can we work? What needs to be done? Wasn't classified to be specific. We have hypertensive urgency and emergency. Now, urgency, it's severe elevation in blood pressure over 120, over 180 and over 110 without progressive end organ dysfunction. Over 120 and over 108 and over 120, over 180 and over 120. Usually here we have end organ dysfunction. Now, hypertensive emergency non-selective beta blockers, labetalol, alpha 1, beta 1, beta 2, reducing both heart rate and peripheral resistance. Esmolol is a selective beta 1 blocker, but it needs continuous IV infusions. Now, arrhythmia. So thank you, and any questions, I'm here. We'll talk about this in a new time, inshallah.